So, good morning everybody. Today we will talk of antimalarials. The easiest topic I find in pharmacology. वैसे तो सारी pharmacology, if you take it in perspective, it is not very difficult. The thing is, you have to get a nick of it, you have to sit with it for some time, and particularly at this stage when you have read the whole thing, it becomes very easy. But this may be because we are reading this topic from, I think, 11th standard. Even before that, nowadays in schools also, the life cycle of malaria, and even in 12th standard you will find some of the drugs are also taught. So malaria, you know, it is there since we know this word, and it is caused by plasmodium. Plasmodium, that is spread by female Anopheles. Various varieties like Plasmodium falciparum in India, particularly falciparum and vivax. They are two major problems, but ovale. And we don't read much about malaria. If you remember, that used to give that quartan fever. Quartan means every fourth day the fever will come. Otherwise, what we get is this tertian fever with vivax and ovale. After every 48 hours, there is chills and fever. So that is very characteristic of malaria. And remember, it's not that, again, we just after independence we tried to eliminate this disease, and somewhere in 58 actually the eradication program, National Malaria Eradication Program, was launched in 58, yes, and that significantly reduced the incidence of malaria. I tell you, even now if you see, there are something around in between 20-25 crore patients of malaria in the world, and in India also, if you see, in early 50s there were at least 7 to 8 crore patients of malaria. Remember, the population of India in 47 was something around 25 to 30 crore. That is what I see in the census records. So almost 1/4 of the population was suffering with malaria in those days. And when this malaria eradication program was launched, suddenly, if you see, in 70s, there were hardly 1 or 2 lakh cases. Huge success. And remember, that is what I say, we learned a lot in health sector, we learned a lot in 60s. Because what happened, because of smallpox eradication, we thought we are really gods. But then we understood a lot of things, and this was the time when epidemiology was coming up. Huge studies were being conducted on various diseases, and we were trying to eradicate. That is why whenever you see in 50s, the name of the program is Eradication Program. And later on, the incidence decreased to, as I told you, 1 or 2 lakhs cases in India, and then suddenly it increased in late 70s. Again, because of resistance to chloroquine. Remember, we didn't have this concept of resistance in 50s, 60s. So we also learned from these setbacks, I would call it. And so later on, all these programs, they became control programs. And now actually malaria is covered under National Vector-Borne Disease Control Program. Various diseases, I told you, filariasis, Kala Azar, Leishmaniasis. So vector-borne diseases. Similarly, if you see the medicines, remember, this had been a very important disease. Though it was known, and cinchona bark, this was discovered, or I won't say discovered, this was known in Peru, and this was being used for fever. Later it was realized that this is not effective in all kinds of fever, and this is specific, and then it was this is more specific to malaria. But it was found out, the quinine was found out in somewhere in 1820. Even after that, this was the main drug. There was no other development. So this was a natural alkaloid, quinine from cinchona bark. But in the First World War, the First World War was a turning point. Remember, same thing I say about antimicrobials. The wars, they were fought by the soldiers, but there was a team of healthcare personnels. This was the time. Remember, what we see now is happening in Ukraine and Russia and this and that and Iran and US. There's no mortality. What we are doing, we are destroying the assets. In those days, this was not the concept. The only concept was to kill the people. And more than the people who were killed by the bullets, they were killed by the diseases. Because the people were staying in those tents, and you see, in monsoons, in rains and there was no concept much of sanitation and everything. There were lots of diseases. And this was, if you could save your people to fight, then only you could win. And this was the time that, because this was coming in the beginning, as I told you, from Peru, but the main source initially in those days, in early 20th century, this was Java. This was the place where cinchona bark was. But what used to happen in the war situations, they would cut off this supply, because this was a part of warfare. And then the discovery started that we should have some chemical that can be found. This is the time, if you see 1920s, 30s, 40s, say 1951, pyrimethamine was launched. And between 20 and 20, Mefloquine came. Mefloquine was discovered by Germans. So this was not a natural product, this was a chemical. And I tell you, even chloroquine, this was discovered by Germans but claimed by US that we discovered it. But this was simultaneously. Actually, the Germans, they had already tested it with some other name, I think Resocin or something. But in US, chloroquine was launched with big fanfare. This was somewhere around 1926. So this was the time, and then came Proguanil. That was also tried in resistant cases. But remember, between these First and Second World War, a lot of things were going on this malaria front. And that really helped. Ultimately, I would say the game changer now in recent times was this Artimisinins. They were describing Qinghausu. Qinghausu is the name. This was Chinese herb basically. So that is the mainstay now, even in India, because most of these organisms, they have developed sporadic resistance, and in some places, like completely, if you see to northeast India, complete resistance to chloroquine, and even sulfadoxine and pyrimethamine. So resistance to chloroquine is a big problem, not only in India but all over the world. But what really happened, I told you. What is done by this organism? Remember, this plasmodium, as I told you, this is spread by female Anopheles. When the female Anopheles bites, this leaves the spores. Spores, we call them. And these spores, they do not cause any fever. When the Anopheles bite, there is no fever. There may be some malaise or something, but these organisms, they go to the liver. And in the liver, what they do, what they do in the liver, क्या है यार, this is known as exoerythrocytic cycle. In the liver there can be two things. One is pre-erythrocytic cycle, we call it. When the spores they enter in the liver, they multiply there, and some of them they do not multiply, they remain dormant, and they are known as hypnozoites. Hypnozoites, they are dormant, and what they do, they remain dormant and they will come back after some time. They will be the cause of relapse. This happens only in vivax, oval, and as I told you, malaria. So in those plasmodium organisms where there is a concept of relapse, that is because of these hypnozoites. Otherwise, what happens? This spore will enter here, and this is, remember, when we say man is not a definitive host, that is female Anopheles. Why? Because in man there is no sexual reproduction of this organism. What we get is asexual multiplication, and that is what we say schizogony. This term you will very frequently hear. Schizogony. This means there is asexual multiplication of the organism. And what they do, another term you will very frequently hear, schizones. Schizones, I remember because of spelling. Schizones. This is what? When this spore enters in the liver, in the hepatocytes, this will multiply. This will keep multiplying, and the cytoplasm around it will also separate. So ultimately what you get, multiple, we call them merozoites, multiple merozoites there, but within a single cell, within a single hepatocyte. The hepatocyte has not multiplied. So what we get is a multinuclear cell, multinuclear hepatocyte. That is known as schizone. And that is why we say erythrocytic schizones or exoerythrocytic schizones. If it is in the liver, in the hepatocyte, this is hepatic schizones, or if it is in the RBC, is the same concept, multinucleated RBC, then it will be erythrocytic schizone. So these are the terminologies. So what happens, it enters in the liver, schizone is formed, and then these merozoites will come out of liver in the blood, and in the blood they will infect the RBCs. Remember, thousands of merozoites you can find in one hepatocyte. When the schizone bursts, there can be thousands. This is not the case with RBCs. In RBCs, depending on the species, you have 8 to 32 merozoites, because when they come out of hepatocyte, they enter in the RBC, and in the RBC also they will multiply similarly. So this is erythrocytic schizone, and when they have multiplied, then the RBC will burst, and this is the time when we get the symptoms. Whenever the RBC bursts, many of these merozoites, they are released in the blood, and this is the time when we get the chills and the fever. So this keeps, if it is falciparum, there is no relapse if I take care. So this will be erythrocytic cycle. It's not that fever will come only once, but what is happening, it is continuing. Whenever these merozoites, they are released, now these merozoites will again infect other RBCs and multiply there, again they will be released. So this cycle will continue erythrocytically. Okay, this will continue in the blood only. So this is not relapse. The fever is coming again and again, but this is not relapse. In relapse, you have treated the patient, everything is perfect, there is no problem, there is a gap of few weeks also, and then the disease will start again, that is relapse. So that is because of hypnozoids which were there in the liver. So you had cleared the blood, but then they will come from the liver again. So these merozoites in the blood, some of them will develop into gametes, male and female. When the anopheles will come, these gametes will go to anopheles, and then they will go in the midgut. In the midgut they will gets into ookinete. They will come, they will meet, and they will be they will meet together, male and female, and what is formed is ookinete. That ookinete enters in the wall of the midgut, comes out of it, and that is oocyst we call it. Many of these sporozoites, they are present in oocyst, then they migrate to the saliva, and that is how the anopheles, it infects the human being. So this is the life cycle of this. Now how can we treat it? We know the cycle. So how can we treat it? One of the mechanism is you treat the organism in the blood, and that is what we do in falciparum. Actually that is known as clinical cure. When we treat the organism in the blood, we kill the organism in the blood and RBCs. Erythrocytic cycle we can call it, or erythrocytic schizogony, this is known as. So when we clear the blood, this is clinical cure. There will not be any fever or something if it is not oval or vivax. Falciparum, perfect, no problem. But in oval and vivax, the relapse will be there. So in those cases we need to take care of hepatic cycle or exoerythrocytic cycle also, and that is what we call radical cure. Radical cure. So one is clinical cure, another is radical cure, remember. So radical cure is required in vivax and oval. And one more thing we should take care of, we should take care of gametes also, because we should strive that the anopheles does not get infected, otherwise then it will spread it. So these are three things. One is hepatic or exoerythrocytic schizogony, second is erythrocytic schizogony, and third thing is gametes. These three things we should take care of. That will become radical cure. Radical cure. Another important thing that we read in malaria is prophylaxis. Now prophylaxis may be required by travelers. If somebody who is not living in area that is infected by this thing plasmodium, then the person should take something so that does not develop the disease. And actually this may be the requirement of many countries. That is what they keep saying, third world countries. When you are traveling to third world countries, remember those countries, they have very strict guidelines. So one of the prophylaxis is this. Second type of prophylaxis can be, if I am living in that area, why should I develop the disease? Why only Americans should have the privilege? So I should also get something so that I don't develop the disease. So that is also a type of prophylaxis. Then we can have some high risk patients also, like say pregnant women. We must strive that they do not develop this disease, because that will be another problem. So there can be various types of prophylaxis, but remember we have learned this thing also. I still remember when I was small child, I was in school, we used to get that chloroquine every week. Every Sunday one person used to come and they used to make us swallow that. It used to be very bitter, so I never liked it, but this was prophylaxis basically, being given to everybody in those days. But now we have understood this also, that prophylaxis may not work this way. Prophylaxis has to be targeted, should not be for a very long period, because remember all these drugs, they have cumulative toxicity. and that creates a problem. So we'll talk about the drugs which are available with us. This is your PH8.7. It covers amoebiasis, kala azar, malaria, filariasis. Amoebiasis is not covered under vector-borne disease. This is not vector-borne. This is basically fecal-oral transmission. Rest of them, they are vector-borne diseases. We have talked about kala azar, I think, and malaria, filariasis. We will see. So many diseases, but I said easiest thing because all of them, they have almost same mechanism of action. They have almost same side effects. Remember. So which are these 4 aminoquinolines? Chloroquine, Atovaquone, Primaquine. We have biguanides like Proguanil. I told you this was launched in 40s. I think Proguanil came in 31, it seems. Sulfonamides, we have sulfadoxine, sulfamethopyrazine, dapsone, all of them are effective. We have amino alcohols like halofentrin, lumefantrine. We have quinoline methanols like Mefloquine. We have diaminopyridines, pyrimethamine, like you have trimethoprim in Septron. Here it is pyrimethamine. Cinchona alkaloids, we know quinine, quinidine we don't use in malaria, but that is also. 8 aminoquinolines are Primaquine, tafenoquine, cisquiterpene, lactones, I told you artimisinins, they are there. Naphthyridine, pyronaridine, we don't, I won't talk about this. This is just like chloroquine. Doxycycline, clindamycin are used, and naphthoquinone, as I said, Atovaquone. This is in combination with Proguanil. This is used. So these are the drugs which are available for treating malaria. First of all, we'll talk about quinine. 2 rings in the structure. As I told you, it's not necessary to remember, but it is like I know somebody. How do I identify somebody? I remember the features, I remember कैसा दिखता है, क्या है. So it is a good habit of remembering the gross structure of drugs. Mug up this mechanism. This is the mechanism with most of the anti-malarial drugs. What happens when the plasmodium sucks the blood of human being? It goes into the digestive vacuoles. These digestive vacuoles are acidic in nature. So this heme from the hemoglobin is metabolized there. The proteins, globins will be separated, and from this hemoglobin, the globins are separated, and what remains is heme. Remember, because the organism is getting proteins and everything from hemoglobin, but this heme, iron containing heme, it cannot do anything with this. This is very toxic for the plasmodium. So what it does, it converts it into hemojoin, crystallizes it. Multiple heme molecules, they will come together, polymerize, and what is that crystalline form? That is hemojoin. This is the target of most of these drugs. So what happens? Quinine, a weak base. All these drugs are bases. Quinine, chloroquine, all of them. And that is why they have this mechanism. Concentrates inside the acidic food vacuole. Okay, this will concentrate. This was acidic environment. So they are basic in nature. It acts as an antagonist that inhibits enzyme heme polymerase. This is another mechanism. One of the mechanism is this will change this acidic nature of the vacuole. So actually the organism will not be able to even metabolize hemoglobin. Second, it inhibits the enzyme heme polymerase. So heme will not polymerize, hemojoin will not be formed. This prevents the polymerization process, allowing toxic heme to accumulate and kill the parasite. This is the mechanism with most of these drugs. We have one dihydrofolate reductase inhibitor with Proguanil or pyrimethamine. That is just one more mechanism. Along with that, because as I told you, I'm not using this term, the exact mechanism is not known. And nobody likes to talk about this in this way. But every 3, 4, 5, 10 years we come up with that this also is the action. So beyond its effect on heme, quinine also disrupts several vital biological processes like interfering with nucleic acid synthesis, inhibiting protein synthesis, and disrupting glycolysis. Additional mechanisms. And quinine also has, when used to treat muscular disorders, quinine also has this utility, like nocturnal leg cramps, though it is not advised that we prescribe it like that. Quinine works directly on muscle membrane. Its mechanism of muscle tissue includes increasing the muscle fibers refractory period, reducing the excitability of the motor end plate to acetylcholine, and redistributing calcium ions. So for this leg cramps, when it is prescribed, then the mechanism of action is very local. So these 2-3 things you have to remember about quinine. Therapeutic uses, malaria, and remember it's not used as a primary drug, but in chloroquine resistance in some areas. Nowadays for chloroquine resistance we use artimisinin containing regimes, ACTs, but this is also effective, and in severe malaria like cerebral malaria, because this is available by IV route. And flavoring agent used in small FDA regulated doses up to 83 parts per million as a flavoring additive in carbonated beverages. Side effects also almost same. This is very specific to quinine, synchronism. In very high quantity, or if when used for a prolonged period in high quantities, then you get this tinnitus, headache, nausea, vomiting, diarrhea, vision changes, blurred vision or altered color perception, and dizziness and vertigo. This is synchronism. Tinnitus you get with chloroquine also, but even synchronism you may get with chloroquine, but more common with quinine. And these are other problems. Arrhythmia, QT prolongation, hemolytic anemia. 2. Number 3, this is not common, like this is hypoglycemia. It increases the insulin secretion. So there may be hypoglycemia. Remember, malaria in itself causes hypoglycemia. When we say severe malaria, then we identify it by hyperpyrexia, hyperparasitemia, hypoglycemia, convulsions, cerebral infection. So then we call it severe malaria. There may be hemolysis or black urine like that. So that is known as severe malaria. So that in itself may happen because of the disease, and quinine also is doing that. Anaphylaxis type of reaction can be with any of them. So these are very common side effects with all of them. Must be avoided or used extreme caution in people having already heart problems, blood disorders, and neuromuscular disorder. We know the reason, because this will create problem. And then comes chloroquine. It is chloro. 4-aminoquinolines, if you remember, we had talked about. This is 4-aminoquinoline, and we have 8-aminoquinolines like Primaquine, Tafenoquine. 8-aminoquinolines actually they came in 60s. We have talked about 8-aminoquinolines in some previous lecture. Antimalarial action, when same mechanism, just like quinine, does the same thing, prevents synthesis of hemojoin, These are other things. As I told you in previous lecture also, chloroquine has multiple uses. So as immunomodulatory anti-inflammatory action, increases the pH of lysosomes inside antigen presenting cells like macrophages. So what will happen because of that? Antigen presenting cells, do they what? They take some protein, digest it and process it. They will break this up, this protein, and will convert it into polypeptides and will take the necessary part of this peptide, and that will function as antigen. This polypeptide will be attached with MHC and then it works as an antigen. This is a basic drug. So this will increase the pH of these APCs, and what will happen? This polypeptides will not be generated. The macrophages will not be able to digest the proteins, and because of that, by diminishing the formation of these peptide MHC complex, we call it, it prevents the overstimulation of CD4 T cells, dampening the immune response. It also suppresses immune activation by decreasing toll-like receptors. This also you can remember. It decreases toll-like receptors, TLR. So these are two mechanisms by which this acts as an immunomodulatory and anti-inflammatory. It has some antiviral properties also. Raises the pH of endosomes, which blocks the acid-dependent fusion and entry of many viruses into host cells. And it also has been shown in studies on SARS-CoV and SARS-CoV-2 to inhibit the terminal glycosylation of cellular receptors, making it harder for viruses to attach and enter the cell. So this is shown as having some antiviral property also. And what are the uses? Used for prophylaxis, used for treatment of malaria, both prophylaxis as well as in amoebiasis. We have talked about the use of chloroquine. Rheumatoid arthritis, immunomodulatory, it is covered under DMARDs. Lupus erythematosus, and I have not written, but we have read like lepra reaction also, we use it, and one or two more of these autoimmune diseases we use it. Most people, these side effects are seen with all anti-malarial drugs. Nausea, vomiting, diarrhea, abdominal pain, headache, anorexia, mild skin rashes and itching. All of them, they will have these problems. Universal. Some dizziness. These are the problems. High dose long-term use cause irreversible retinal toxicity. This is very unique to chloroquine, leading to blurred vision, light flashes or blind spots. Actually, when it is used as a DMARD, they go for vision check very frequently. Can cause dangerous arrhythmias, QT prolongation, I told you in quinine also. Peripheral neuropathy, can result in hemolytic anemia, especially in G6PD deficient people, can cause hypoglycemia. So quinine and this have same, except here there is ocular toxicity, and we have to be very careful. Atovaquone, see, almost same structure. This has changed. Rest of it is like chloroquine. Liver metabolizes atovaquone into its principal biologically active metabolite, that is des-ethyl-atovaquone, responsible for the prolonged antimalarial activity and efficacy of the drug even against certain chloroquine resistant strains. Enters the parasite, same mechanism as chloroquine. Uses Again, same, Atovaquone also has been used for prophylaxis also, but in short course chemotherapy. This is very important. Used safely in children in combination with SP sulfadoxine pyrimethamine to prevent malaria during high transmission seasons. Atovaquone operates as a ribosome biogenesis inhibitor in certain human cancer cells. This is for MCQ purposes. So this has been also being tried as an anti-cancer drug, triggering P53 stabilization and inducing stress on cancer cell proliferation. So sometimes in competitive exams it is asked that what is the anti-cancer mechanism of Atovaquone. So this is the mechanism. Say due to safety concerns we don't use it, the line is gone, as a prophylactic agent. So we are using it only for treating adverse effects. These are same. Remember, fatigue, nausea, vomiting, abdominal cramps, skin rashes, pruritus. They are seen with all of them. Headaches. These are hepatotoxicity with Atovaquone. Agranulocytosis. This is also seen. When it is used for a long time, retinopathy also just like chloroquine, ocular manifestations, QT prolongation, hypoglycemia, involuntary movement. This is unique to this, involuntary movements and muscle spasms. Actually, Atovaquone went out of favor, and particularly in prophylaxis, because of agranulocytosis, hepatotoxicity and involuntary movements. This is the reason given why it is not used for a prolonged period. Mefloquine. Mefloquine, fluorinated 4-quinoline methanol compound, primarily used as a blood schizonticides. All of them actually what we have talked till now, they are only blood schizonticides. To treat and prevent also, Mefloquine is used. Even in some parts of India for prophylaxis, Mefloquine is used. Directly targets, this mechanism is different with Mefloquine. Directly targets 80S ribosome of the malaria parasite by binding to the ribosomal GTPase associated center. The drug disrupts the translation of mRNA, effectively halting protein synthesis and causing parasite death. This is the primary mechanism, and secondary that homojoin theory is there. That is also there. But inhibition of protein synthesis with Mefloquine, that is one of the reasons that it is effective in chloroquine resistant cases also. Mefloquine binds to several human neurological receptors, which causes its well documented neuropsychiatric side effects. Key off target activities are serotonin receptors, act as a partial agonist on the 5-HT2A and 2C, and antagonist on 5-HT3 and GABA A receptors. So this is with Mefloquine. And uses malaria treatment, malaria prevention, I have told you. Adverse effects, these are same. Sleep disturbances are there because it has neuropsychiatric problems. These are the unique things. Carries significant warning, including an FDA black box warning regarding potentially severe mental and neurological adverse effects. Anxiety, severe depression and paranoia. Hallucinations and psychosis, seizures and convulsions, suicidal thoughts and behaviors, loss of balance, severe vertigo and tinnitus. This is unique with Mefloquine, you have to remember. Some rare cases, these neuropsychiatric and neurological symptoms can persist for months or years after discontinuation. Due to its strong neurological and cardiac side effects, Mefloquine should not be prescribed to individuals with a history of all these diseases. If had mental problems, had cardiac problems, had seizure tendency, should not be prescribed. Again, There will be interactions, quinine, quinidine, halofentrin. This is the most important interaction. Both drugs prolong cardiac repolarization, markedly increasing the risk of life-threatening ventricular arrhythmias, torsades de pointes. So mefloquine with halofentrin not used. These are all drug interactions. We know it has QT prolongation, seizure tendency, so we should not mix with all those drugs. Primaquine, this was a game changer in 60, I think launched it somewhere in 63 or 64. 8 aminoquinolines, again bicyclic, we can see. Requires metabolism by the CYP2D6 system to form active hydroxylated metabolites. Active metabolites enter the parasite and targets its mitochondria. This is, remember, one of the very, I should say, most important drug for radical cure. We don't have many of them. Severely inhibiting mitochondrial respiration and ATP production, which leads to cell death. Unique mechanism. Mitochondrial respiration and ATP production is inhibited. Drug and its metabolites undergo redox cycling, which results in the excessive generation of reactive oxygen species like H2O2, hydrogen peroxide. This causes fatal oxidative damage to cellular components and the parasite's DNA. Directly interferes with the mitochondrial electron transport chain of the parasite, cutting off essential metabolic pathways. So these are the mechanisms of primaquine. They are different from chloroquine. Malaria relapse, I told you for radical cure we use it. Malaria transmission blocking eliminates the gametocytes, preventing mosquitoes from spreading the infection. And malaria prophylaxis also, though remember primaquine particularly not very popular as a prophylactic agent because of its hemolytic tendency. So we cannot give it for a very long period. And when we say prophylaxis, this means I am going to take it for a long period. Common adverse effects, these are same. These are the problems. There should be G6PD testing before you give primaquine ideally. One is hemolytic anemia, second is methemoglobinemia can occur in patients with NADH methemoglobin reductase deficiency. One is hemolytic anemia, second is methemoglobinemia with primaquine, and third is prolongation of QT interval. Tafenoquine, just like primaquine, long-acting 8-aminoquinoline, same mechanism, generation of toxic ROS, destroy the parasite cellular component, interfere with the parasite's mitochondrial function, same mechanism as primaquine with tafenoquine also. Unlike many standard antimalarials, tafenoquine is active across multiple life cycles. We have talked about primaquine also, radical cure. So this will also act on hypnozoites, this will act on blood stage, this will act on gametocytes. So same as primaquine. Again, uses are also same. Remember, tafenoquine in India, it has gone phase 3 trial and it has been approved, but we do not find it in any program yet. But if you have problem with primaquine or something, tafenoquine is available. Adverse effects, they are same. Severe hemolysis is there. Psychiatric symptoms with tafenoquine also. This vortex keratopathy and retinal abnormalities. Vortex keratopathy with tafenoquine. And basically deposits in cornea, vortex keratopathy and retinopathy both. Contraindicated in pregnant and breastfeeding women. Pipraquine, see the structure. This gives us idea. This is effective in chloroquine resistant malaria also. You know, one of the mechanism why? Because one of the mechanism of development of resistance to chloroquine is the organism expels, pumps it out, transporter. That is Plasmodium falciparum efflux transporter. This is such a bulky molecule, it is not transported by that same gene. Remember, there are two mechanisms. One I told you, this efflux transporter, and another, if you remember, we talked about, or in some video we talked about that ABC, P53 glycoprotein. That is also an efflux transporter. So that is known as MDR gene. It's an ABC MDR gene. We talked about it at that time. So that mechanism also is seen with chloroquine. So these two mechanisms are there for development of resistance. So it is such a bulky molecule, it is not transported, and so this remains effective. Polymerase, same mechanism, there is no difference. As a bisquinoline, this is a bisquinoline. This is quinoline, this is quinoline. So this is a bisquinoline. Pipraquine has a bulky structure, that is what I told you. Treatment and prophylaxis. Though pipraquine is not as such there, but it is effective as a prophylactic agent because longer acting also, and effective in resistant also. Again, same problem. Structurally similar antimalarials, pipraquine can cause dose dependent prolongation of QT interval. Red and white blood cell count may drop, though this can also be an effect of the malarial parasite itself. Lumefantrine, halofentrin we have not talked. Basically nowadays we use lumefantrine, synthetic racemic fluorine derivative belonging to the aryl amino alcohol class of antimicrobials, completely different from what we know till now. Binds to free heme, preventing this polymerization, same mechanism. Inhibits the parasite's nucleic acid and protein synthesis, same as done by quinine. Most commonly combined with artimether. Basically, we'll talk about ACTs. With artimether it is combined. This has a very long half-life, because it undergo enterohepatic circulation also, and volume of distribution also is very large. So normally also lumefantrine has a half-life of around 2 days, but in malaria patients it is observed that it becomes almost 5 to 7 days half-life. Some of the scientists suggest that it also interacts with the ion transporting mechanism of the organism, additional mechanism. So we'll talk about, you use it in resistant cases, basically treatment of resistant cases. Same as quinine. QT prolongation, allergic reactions, not recommended during first trimester of pregnancy, and drug interactions taken alongside certain medications like halofentrin we have talked about, we should not use them together. This is, I told you, the game changer, artimisinin. This is general structure. This is almost same. Why? What is important basically is this endoperoxide bridge. This interacts with the iron in the heme, and this opens, and then it becomes very toxic. When it combines with the iron that is present in the heme, this bridge opens. This is a bridge. This opens, and this compound becomes very toxic for the organism. The unleashed free radical randomly attack and covalently bind to essential parasite proteins. This damages the parasite cellular machinery, including key enzyme like Plasmodium falciparum ATP6, that is a calcium pump. Damage to protein results in a buildup of toxic misfolded proteins. The drug interferes with the parasite's proteasome system, which normally clears out this debris. And because of this, this debris will accumulate and will be lethal for the organism. So two things. One is this endoperoxide bridge opens after interacting with the heme. This starts killing the proteins. I shouldn't say clearing it, this starts breaking the proteins, important proteins. And it does not allow the scavenging work also. That is done by proteasome system. So because of that, many of these defective proteins, they will accumulate in the organism, and this accumulation of waste damage proteins and oxidative stress ultimately leads to rapid parasite death. Malaria treatment, severe malaria, will talk about emergency research. Clinical research investigates the compound for potential anti-inflammatory, antiviral and anti-cancer properties, as it can reduce cell death in highly metabolically active cells. It has been observed. Most common side effects include nausea without neurological symptoms, include dizziness and headache, just like quinine. High dose cases neurological or psychiatric effects, Mefloquine. Rare instance of arrhythmia. Prolonged high dose use carries a risk of hepatotoxicity or mild blood dyscrasias. As with any medication, severe allergic reactions, anaphylaxis is possible. Then these are the drugs 2-3 which have different mechanism. This is pyrimethamine, folic acid antagonist, completely inhibits enzyme dihydrofolate reductase, insusceptible protozoa, blocking the reduction of dihydrofolate to its active reduced form, that is tetrahydrofolate. Tetrahydrofolate is an essential cofactor, we know, for synthesis of DNA. Pyrimethamine is co-administered with sulfonamides such as sulfadiazine or sulfadoxine. The sulfonamide acts early in the pathway, so this becomes synergistic combination like we know about Septron. So here we use sulfadoxine and pyrimethamine. This is also used in toxoplasmosis and malaria, Toxoplasma gondii. Higher doses required. Toxoplasmosis can cause vomiting, nausea, abdominal cramps, headache, dizziness. Same. We give leucovorin, folinic acid with it. Can lead to, if we don't give, it can lead to megaloblastic anemia. Potentially life-threatening conditions like Stevens-Johnson syndrome, exfoliative dermatitis, Stevens-Johnson syndrome. Rarely it can cause arrhythmias and pulmonary eosinophilia. Increase eosinophil count in lungs. Because of these problems, Stevens-Johnson syndrome, exfoliative dermatitis, this is not used for a long, actually this is used as a single dose. SP will talk about. Pregnancy, we should not use it, and there are so many drugs in drug interactions also. Proguanil also has the same mechanism. See the structure is different. Monotherapy. Taken alone, Proguanil is converted to cycloguanil, which acts as a potent inhibitor of the parasite enzyme DHFR. Same mechanism. By shutting down this recycling process, tetrahydrofolate is depleted. This starves the malaria parasite of the folate needed for synthesis of DNA. So same mechanism. This is combined with Atovaquone. Combination therapy, synergy with Atovaquone. When combined with Atovaquone, Malarone, Proguanil plays a distinct and different role. Atovaquone acts to inhibit the parasite's mitochondrial electron transport. Proguanil synergistically works to collapse the parasite's mitochondrial membrane potential. So it is synergistic, not in case of DHFR like sulfadoxine pyrimethamine. This is here on the mitochondrial toxicity. They are synergistic. This dual action enhances the drug's ability to trigger a mitochondrial cell suicide or apoptosis cascade. It also drastically reduces the parasite's ability to develop resistance to Atovaquone. So single, that is the reason I told you in 40s, Proguanil was used alone, replaced chloroquine, and because it had some activity against gametes also and pre-erythrocytic cycle also. So this was found very effective, but within a decade it was found out that the resistance develops very fast, and so Atovaquone, it delays this development of resistance. Common side effects are same serious side effects: exfoliation, dermatitis, blistering, loosening of the skin, just like in case of pyrimethamine, hepatotoxicity, jaundice, light colored stool, severe upper stomach pain, urticaria, itching, hallucinations, seizures or sudden loss of consciousness may occur with this. What are the regimes that we have? What do we have? It will take 5 minutes. Remember, if it is uncomplicated Plasmodium falciparum, the simplest thing, what can we do? We give chloroquine. Chloroquine, we always talk in terms of base, but it is available as chloroquine phosphate or hydrochloride, but most commonly it is phosphate. So remember, phosphate 1000 milligram means 600 milligram of chloroquine base. Always prescribed in terms of base, because say hydrochloride, it will be equivalent to 750 milligram to 600. So it is always prescribed in terms of base. So what we do, the regime is same that I was taught in MBBS. On the first day we give 600 milligram stat. We can call it loading dose. 600, I am talking about base. Remember, the tablet is available, 250 milligram tablet that contains 150 milligram chloroquine. So we give 4 tablets. That is what we were taught in community medicine. Give 4 tablets stat, 2 tablets after 6 hours, and from next day 1 tablet BID for 3 days. So total dose, this comes out to be something around 25 milligram per kg. 600 milligram stat, 300 milligram after 6 hours, and then 300 milligram per day in 2 divided doses for 3 days. This is the regime of chloroquine. But as I told you, nowadays chloroquine resistance is prevalent. One more thing you should remember, even if it is falciparum, we have to give Primaquine. Because in case of falciparum, this would act as a gametocidal. We do not want that this should spread. But remember, if it is Plasmodium falciparum, we give single dose of Primaquine, and that is 45 milligram. If we are giving it as gametocidal, then the dose is single dose, that is 45 milligram. If we are giving Primaquine, I may forget, remember, we must give Primaquine in all the cases, be it falciparum or in case of Vivax and Oval. Primaquine is given 15 milligram per day for 14 days. Because there we are not using it only as gametocidal, we are using it as a radical cure, hepatic schizogony. We are trying to kill the hypnojoints. So there 15 milligram for 14 days always take care of G6PD. This is in every case. And for clinical cure, I told you about what we do with chloroquine. But as I told you, resistance is developing very fast. What is the alternative? The alternative to chloroquine can be quinine, (600 milligram 3 times a day for 7 days). But not alone. Doxy. We have not talked, but you have read about doxycycline. 100 milligram per day for 7 days. Same. Alternative to doxy, clindamycin, 600 milligram twice a day for 7 days. Don't forget Primaquine. Depending on which organism is this, falciparum single dose, vivax or oval for 14 days. But as I have told you, quinine also is a very toxic drug. So what do we have? What we have is, we call them ACTs, artemisinin containing therapy. There are various ACTs available. I'll tell you about 5 or 6 of them. One is artemether. Remember, 2-3 drugs are used. One is artesunate. Artesunate is given either as a single dose of 200 milligram or 100 milligram BID. It is water soluble. Remember this. Artesunate is water soluble, so it is available for IV use also. Artesunate is combined. The problem with artemisinin containing artemisinin drugs is they are very short half-life, 1 to 3 hours, roughly 2 hours you can remember. So they are not used alone in malaria. Indication: chloroquine resistance malaria. And nowadays, actually, in National Vector-Borne Disease Control Program, they are also prescribed as a first-line drug. ACT is also prescribed as a first-line drug because we don't know which organism has developed resistance. But there are at least 6 or 7 WHO regimes. Out of them, 1 or 2 has been taken up by National Vector-Borne Control Program. So this artesunate is combined with Mefloquine. Why it is combined with these Mefloquine, Atovaquone? Because they are longer acting. Mefloquine, I told you, this can have a half-life of around 2 to 3 weeks. So Mefloquine, another artesunate with Atovaquone. Artesunate we write as AS, ASAQ, ASMQ. Artesunate with Atovaquone. Atovaquone is used as 600 milligram per day. And actually ASAQ is available as a fixed dose combination also. And that is why in ASAQ the dose is 200 milligram once a day with 600 milligram Atovaquone. Here it is 100 milligram BID with Mefloquine. Remember, Mefloquine is not given for 3 days. These are all 3-day regimes. ACT regimes are 3-day regimes. 100 milligram BID artesunate, Mefloquine on 2nd day 750 milligram, on 3rd day 500 milligram. This will be ASMQ. ASAQ 200 plus 600 daily for 3 days. And there is one more regime in India. Artesunate, suppose, is combined with ASSP. Artesunate, sulfadoxine pyrimethamine. I remember is right from those days 1575. Sulfadoxine 1500 milligram, pyrimethamine 75 milligram. So 1575. And this is, I told you, 100 milligram BID for 3 days. And this I had told you at that time also, this is given as a single dose. So on 2nd day you give 1 dose, or 1st day. On 1st day you give SP 1575, artesunate 100 milligram BID for 3 days. And never forget Primaquine. that you can give on first day, you can give SP, on second day you can give Primaquine. Okay, so this becomes, these three regimes become artesunate containing regime. Then it has been observed that in northeast actually this SP has also developed resistance, and so there we don't give SP, sulfadoxine pyrimethamine. What do we give there? We use AL, artemether lumefantrin. Artemether lumefantrin. Artemether is not water soluble, but here it is available as tablet. So what do we give? 80-480, 1:6 combination. Artemether 80, lumefantrin 480. Twice a day for 3 days. 6 doses we give. So this is the regime. Actually this is primarily followed in northeast, AL regime. Then we have talked about Pipraquine also. Pipraquine, I told you, in chloroquine resistant cases that can be very effective. So Pipraquine is combined either with dihydroartemisinin, dihydroartemisinin is combined with Pipraquine. One is to 8 ratio, 120 milligram, 960 milligram. So this is one regime again for 3 days. And when I see FDC of this, I find, I don't know why, how are they using it in India? I don't think this is so commonly used, because when I see the fixed dose combinations, I always find dihydroartemisinin 25 combined with 67.5 Pipraquine. If it is 50, this is 135. If it is 100, this is 270. But 1:8 is the ratio. 120, 960 per day for 3 days. Another, arterolane is developed in India. This is artemisinin, arterolane, oxolane derivative. Arterolane combined with Pipraquine, 150, 750. Again for 3 days. So this is also one of the so they are, what I've told you, these 6 or 7 of them, they are known as ACT, artemisinin containing therapy, used either as a first line or in cases of chloroquine resistance. Then one more thing, that is severe malaria. I have told you about when we call it severe malaria, what we need parenteral therapy. So I told you quinine can be given as a IV, but very high doses, like 20 milligram per kg we give immediately. Then after 6 hours, after 8 hours suppose, or in case of IV we can say after 12 hours, because remember when quinine is given by IV infusion, this has to be given over a period of 4 hours, dissolved in dextrose or dextrose saline. So 20 milligram per kg mix, give over a period of 4 hours. After 12 hours you give 10 milligram per kg, and then every day you go for 10 milligram per kg. 8 hourly you go for 10 milligram per kg. Very problematic. So what do we have? Artemisinin. Artesunate, I told you it is water soluble, can be given IV, 2.5 milligram per kg every day. Every day you go for 2. Sometimes they give loading dose also, but 2.4 milligram per kg go every day IV infusion. Or artemether, you have to go for intramuscular. You cannot give IV because this is dissolved in oil. It is not water soluble. Actually rest of them, artemether, arteether, they are not dissolved in water, they are oil dissolved. So we give them IV, we give them IM, 3.2 milligram loading dose, and then 1.6 milligram per kg every day. Artemether. Arteether you give for 150 milligram every day. So these are along with If we want to give other medications of combination, then we can, but this is to be given parenterally. And remember, when the person recovers or is able to take oral, then we have to go for 3-day course of oral therapy. Always remember, we have given IV, everything we have done. Even with quinine, when the person is perfectly all right, then you go for 3-day regime of these ACTs. So this is how we treat malaria. These are the questions which are asked. ACT is very frequently asked question, and severe malaria is another problem. So this is sufficient.